Vet Emergency and Specialty Hospital, and tonight I'm going to be going over an introduction to diagnosis and staging of cancer. This is going to be not specific cancer, just kind of cancer and as a whole disease process. So here's a kind of roadmap of what we're going to talk about tonight. So just give a general overview of cancer, go through what a history and physical exam might look like in a potential cancer patient, what diagnostics we'd like to do, and what we'd like to do for staging. So first overview. So just a couple statistics for cancer. So approximately 1 out of 4 dogs will develop cancer at some point in their lifetime, and that's a similar number in cats. Nearly about 45% of dogs over the age of 10 years old are diagnosed with cancer. What are the most common tumor types that we see? These are not exclusive lists, just a couple of the most common ones we see. So in dogs, we see lymphomas actually accounts for 7 to 24% of all canine cancers. So it is one of the more common ones that we see. Mast cell tumors, osteosarcoma, melanomas, mammary gland carcinomas, and hemangiosarcomas are also very common. For cats, we also see a good number of lymphoma cats, mammary tumors, squamous cell carcinomas, and fibrosarcomas, also called injection site sarcomas. So a little bit of housekeeping. So a couple definitions that I'll be using throughout the lecture. So when I say tumor, that means any tissue mass or swelling that can be further classified into benign or malignant. A benign tumor is a tumor that is unlikely to spread and usually has a favorable prognosis with the correct intervention. A malignant tumor is a tumor that no longer resembles the cells that it was originally derived from. It's usually invasive at the site that it is, and it has the potential to metastasize, which is spread throughout the body. When I specifically say cancer, I'm referring to that malignant category of tumors. So how does cancer arise? Many studies have been done both in veterinary and human medicine and cancer has been defined as a genetic disease. It's an accumulation of mutations that take away the normal limitations of cell growth and proliferation. And there are many reasons this occurs that I'll go through. But first, what are the hallmarks of cancer? What makes cancer cancer? So cancer is not a single gene is responsible for transformation of a cell into cancer. Its cells are regulated by many biochemical processes, and multiple mutations along these biochemical processes are what causes a cell to transform and progress to cancer. So one of the most important hallmark of cancer is that it has to be self-sufficient. Cells divide and grow based on external signals from the body, and those signals are stopped once those signals decrease. Cancer cells develop a mutation that they can grow and proliferate without that initialing signal, and they don't stop growing if there is a signal once that signal decreases. So in addition to being able to grow, it also has to evade the body trying to stop it from growing. This is usually done through genes naturally found in the body called tumor suppression genes that balance the growth proliferating signals. A mutation in this tumor suppression gene is found in virtually every cancer, but that's both in veterinary and human literature. It also has to evade cell death. Every cell in the body has the natural ability to destroy foreign cells. That's a process called apoptosis, natural cell death. Cancer evades this process through loss of a gene that allows it to occur, or gain of a gene that doesn't allow it to occur. Cancer also has limitless replicative capacity. Cell normal genetics limit the number of times a cell can divide. Cancer doesn't have this stopping point, essentially making it an immortal cell that can't die. Sustained angiogenesis. cells must have a blood supply in order to survive, and if the body isn't going to provide that for them, they have to make their own blood supply, especially as a mass gets bigger and outgrows that blood supply and has to have a way to make more. And the last one is that it has to have the ability to invade and metastasize. The mechanism for doing this is not fully understood, and different cancers do this in a variety of ways. So what are some predisposing factors to developing cancer? One is it's hereditary. We know that some breeds are at higher risk for developing certain cancers than others. Golden retrievers are more likely to get hemangiosarcomas and lymphomas. Boxers like to get mast cell tumors. Giant breed dogs such as Great Danes, Irish Wolfhounds like to get osteosarcoma. Chemicals, specifically pesticides, herbicides, insecticides, can predispose to cancer. There's actually been a few studies that show that homes, lymphoma cases are more likely to come from a home that was professionally treated with insecticides, pesticides in the home. Radiation, including sunlight. It's been shown that lighter skinned animals, especially white cats, are with long-term cumulative exposure to sunlight actually have a higher risk of developing squamous cell carcinomas. A young animal that had a tumor removed and went to radiation therapy can also develop a secondary tumor in that site of radiation after so long after the initial radiation therapy as well. Inflammation, specifically chronic inflammation, allows those cells to acquire hallmarks of cancer that I talked about. This is the mechanism by which we think injection site sarcomas in cats occur. Hormones. Canine mammary cancer is the most common cancer of intact female dogs. It has been shown that if you spay them before the first estrus, getting rid of those hormones from the ovaries significantly decreases the chance that a dog will get canine mammary cancer. That risk goes up to 26% if you wait until after the first estrus. Similar risk in cats. There's been a 7-fold decrease in risk if the cat is spayed before 6 months of age. And the last one I'm going to talk about is viruses. The most well-known of these is feline leukemia virus, feline immunodeficiency virus. It was believed that 20 years ago, before we started vaccinating for feline leukemia virus, that 70% of all the cat lymphoma cases were FELV positive cases. There was a 62% chance that you would develop lymphoma if you had if you were FELV positive compared to negative ones. So this is just a chart kind of going through a benign versus a malignant process. So the shape, usually, this is just generalities, not in every case. A benign tumor is very round, wart-like, pedunculated. Looks like you could just pick it off without any further intervention or surgical intervention. Malignant, they're sometimes fixed to the skin, they're irregularly shaped, they're hard, they're knobby, very compared to the benign masses. Metastasis, benign is usually not present, and malignant tumors have the potential to metastasize. Mitotic figures, when looking at the cells under a microscope, there aren't very many in a benign tumor, whereas they are in a malignant tumor where they're growing faster, the cells are dividing much more, so we see a lot more mitotic figures. And blood supply, benign, usually much less, malignant, much more, goes with the sustained angiogenesis as a hallmark of cancer. So we're going to forget about the benign column for the rest of this lecture and focus on the malignant column. So moving on to our history and physical exam, what might we see? Well, the first thing we might see is cachexia and weight loss, whether that be acute or chronic. Hyporexia, anorexia is a common symptom we see in potential cancer patients due to the amount of inflammation that cancer causes. Also an increase in metabolism and loss of lean muscle because you are growing a tumor that has higher nutritional and metabolic demands that the body isn't used to keeping up with. And also if a cancer is directly interfering with taking in nutrients, metabolizing nutrients, such as a GI tumor or an oral tumor that may not make them want to eat because it's painful in their mouth. GI signs are also very common. Melena is specifically very common with mast cell tumors and bleeding intestinal masses. Mast cell tumors increase gastric acid secretion, which makes it more likely for them to form ulcers. Vomiting, diarrhea are very non-specific signs that are seen in many cancers as well. They don't feel good. They're going to have further GI signs. Fever, we can see fever, whether it be a severe fever or just a mild fever. That goes along with the immune system and inflammatory response against the tumor or tumor necrosis. As that mass grows and outgrows its blood supply, it dies. The inflammatory response against those dying cells can cause a fever. We can also see a fever with secondary infection, especially as in ulcerated masses. Mast cell tumors are very common to get ulcerated. If we have sepsis with a perforated GI tumor, or if a patient is already undergoing chemotherapy and they get a low neutrophil count, they can get a fever as well. Lameness, this can occur with any cancer affecting the limb, the most obvious one being osteosarcoma, but tumors affecting the nerves that affect the legs can also cause the lameness, such as a peripheral nerve sheath tumor. A pulmonary tumor can also cause changes in the long bones that can cause a lameness as well. We can see dermatologic changes, the most common being alopecia or just generalized hair thinning. Any endocrine tumor, we can commonly see skin changes as well, or just any endocrine disease, such as diabetes, Cushing's, hypothyroidism. And the last thing we can see is we can see neurologic manifestations. Obviously, we see neurologic changes with tumors affecting the neurosystem itself, such as the brain or nerves. We can see mentation changes or neurologic deficits on our physical, but we can also see peripheral neuropathies. As the body attacks the cancer, it can attack normal cells as well, including nerves. So we can see peripheral neuropathies, including myasthenia gravis. And we can also see other immune-mediated conditions, such as immune-mediated hemolytic anemia, thrombocytopenia, and polyarthritis. So moving on to diagnostics. I'm going to go through the different sampling we do. You see a mass, you're going to want to sample it, get an idea of what this mass is. Is it benign? Is it malignant? What do I need to do about it? There are two main types of sampling, cytology and biopsy. Going through core diagnostics, that's your blood work, that's your complete blood count, that's your serum chemistry, that's your urinalysis. And also imaging, radiographs, both abdominal, thorax, limbs, abdominal ultrasound, computed tomography, which is CT, and MRI. Couple more definitions that I'm going to use in this section. So an aspirate is the process of using a needle to extract cells from tissue. A cytology is a microscopic examination of those cells from the aspirate. A biopsy is the removal of an examination of specifically tissue rather than just cells for the cytology. And grading is looking at that biopsy, evaluating the microscopic features of it, and assigning a grade to predict how aggressive the tumor is. This is done with a pathologist. So going through, what will you need to do a fine needle aspirate for a cytology? Going through the main things you're going to need, depending on where the tumor is and everything, you'll want some alcohol gauze to kind of wipe that area, make it as clean as possible, make sure you don't get any debris or anything in when you stick the needle in. Clippers to clip any hair around the area if it's a long-haired dog or cat. An EDTA tube for any fluid that might be in the mass itself. 5 or 6 mil syringes, get a couple of them using 20 to 22 gauge needles, new glass slides with a frosted edge and a pencil to label, a slide box, and gloves. So how do we go about acquiring our sample? Cytology is the most common method of sampling masses, and there are a couple different techniques. The picture to the right, on the right side of the screen, is called the aspiration technique, where you place a 20 to 22 gauge needle on about a 5 mil syringe. You insert the needle into the mass and you pull back the plunger a few times in order to extract cells from that mass. You redirect the needle to get a good representation of that mass. You let the vacuum go out of the plunger, you exit the lesion, detach the needle from the syringe, fill the syringe with air, reattach the needle, and expel the contents on a slide. The fenestration method is very similar to this, only you just hold the needle by the hub itself. You don't attach the syringe. You just have the syringe waiting, filled with air on standby to connect it to your needle and expel the contents on the slide. The other thing way we can get a cytology is ultrasound guided. We'll go through this with diagnostics and staging, but we see something, an abnormality on ultrasound, we use a needle to make sure that we are in the mass, in the lesion itself, as you can see by the white arrows, and we get a sample of that, expel the contents on the slide. So we have our sample. Now, how do we prep the slide in order to get in order to evaluate it appropriately? So once it's expelled on the slide, you take a second slide, place it gently over the first, either at a 90 or 180 degree angle. The 180 degree is shown in the picture to the left. Kind of let the second slide settle on top. The weight of that slide, the second slide, will compress the material. You don't want to press very hard, because that can cause the cells to break and potentially not have a diagnostic sample. As after the weight's kind of settled, pull the second slide away from the frosted edge, so essentially pull both slides apart to spread the sample out, keep the sides flat and parallel to each other. And if this is done correctly, you'll actually have 2 slides to prepare for cytology. So 1 sample, get 2 slides out of it. So we have our sample. What kind of cells might we see once we look at it? So I'm going to go through the different classes of tumors and examples associated with them. So we can see mesenchymal tumors. Those are your connective tissue tumors, your cartilage, your bone, your muscle, your vasculature. These are your sarcomas, including osteosarcoma, hemangiosarcoma, fibrosarcoma. And they are kind of spindly shaped on cytology. I'll have pictures for you in a moment. Epithelial tissues, these are obviously epithelial in origin. These are your carcinomas. These are your squamous cell carcinomas, your mammary carcinomas, your pulmonary carcinomas. They're kind of polygonal shaped and they like to stick together in little rafts of clumps. Then you have your round cell tumors. Those are 5 discrete tumors. That's lymphoma, histiocytic sarcoma, your plasma cell tumors, mast cell tumors, and transmissible venereal tumors. Then you have neuronal tumors, glial cells or meninges, and you have gonadal tumors coming from your ovaries or your testes. So this is a picture of a mesenchymal tumor. This is specifically hemangiosarcoma. On this slide, the tiny picture on the left is a mitotic figure, indicating that it's more likely to be malignant. And you can see these kind of spindly shaped cells that are larger in the middle and taper to the ends. This is an epithelial class of tumor, specifically a pulmonary carcinoma. You can see they're kind of polygon shaped. They like to stick together and they're pretty uniform in shape. Round cell tumors, on the left is a mast cell tumor. All of the little stained dots are granules from the mast cells That's the histamine that increases gastric acid secretion I talked about earlier. On the right is lymphoma from an aspirate of a lymph node. So moving on to our second type of sampling, biopsy. So what's the indications to do a biopsy? One, if our fine needle aspirate is not diagnostic. It was too bloody of sample, we didn't get good cells, we couldn't prepare it properly, something that makes it non-diagnostic, and we need to do something further. If another indication would be if the extent of treatment would be altered in any way, meaning if we would do a radiation versus chemo versus surgery, if we would do a wide excision versus just a marginal excision, if a tumor is in a difficult area for reconstruction and planning is needed to prepare both the patient and the client. So if by reconstruction, I mean if this is a tumor that would need a amputation or skin flaps or a maxillectomy, we may want to know what it is before going in and taking it out, kind of know what we're dealing with before going in. Or if knowing the results will change the willingness of the client to move forward. As I mentioned before, biopsy gives us a grade, and if that comes back as a high grade, the client may not evaluate for any further care because the prognosis is poor. They may elect palliative care or even euthanasia, depending on the quality of life of the patient. So what are some contraindications to do a biopsy? Cases when the type of treatment or extent of surgery wouldn't be changed knowing what it is. So those, for example, a testicular mass or splenic mass, it doesn't matter what it is, it needs to come out. When a surgical procedure to obtain a biopsy is just as risky as just removing it. So if there's a spinal cord tumor or a very risky place tumor, why get a biopsy when you can just go in and take it out, especially if the biopsy comes back, hey, you need to take it out and you have to do another risky surgery to provide care for that tumor type. And then in these cases, excisional biopsy of the tumor would be better indicated, followed by histopathology to figure it out. So remove it, then figure out what it is. So there are quite a few methods to do biopsies, and we'll go through each one of them. The first one is a needle core biopsy. These are your true cut biopsies. There's a variety of type of tools that you can use. The true cut is just a common I refer to. These can be used on any accessible mass. They're most commonly used on masses you can palpate externally. You usually don't need too much, just a aseptic prep, a local anesthetic, and a little bit of sedation. And the picture here to the right kind of shows that you'll make an incision, you'll put the needle in, you'll get your sample, take it out, and you can actually go through the same incision to get multiple samples of the tumor. Punch biopsy is the next one I'll talk about. It can also be used on any external tumor. It's commonly used for skin, oral, and perineal tumors. Also, if you want to do a liver biopsy, if you're already in the abdomen during surgery, like saying, hey, that liver looks abnormal, let's take a piece of it. Punch biopsy is very commonly used. It's not good for tumors not on the skin surface. So if it's sub-Q or deeper, these usually aren't recommended unless you incise over that skin first and have more access to the tumor. These are relatively simple. You aseptically prep the area. You use a punch biopsy that is essentially a circular blade. You push that needle and kind of spin it in to cut into the skin. You take the punch biopsy instrument out, grasp the gently by forceps, and then cut it from the bottom either with a blade or scissors. This picture will show both incisional and excisional biopsies. So incisional is this top dotted line. It's a biopsy it's a larger sample. If a needle core biopsy or a punch biopsy aren't adequate, aren't diagnostic. This is good for ulcerated or necrotic lesions or biopsies during surgery. It's potentially ones where you can't take the whole tumor, the whole affected area out, but you can take a piece of it to potentially get an answer. Excisional biopsy is similar to what I talked about earlier. We do those when treatment wouldn't be altered with knowledge of the tumor type. You're essentially taking the full lesion out and then sending it to pathology and figuring out what it is. These are your testicular and splenic tumors, for example. This form of biopsy can be both diagnostic and curative, depending on what type of cancer it comes back as. Other methods we can use, more specific methods. We can do endoscopic biopsies, which are either the upper or lower GI tract. It can essentially be used on any hollow lumen. It's a video camera that goes in both the mouth and the butt, and then you can use a forceps to take biopsies while you're visualizing any lesions in the GI tract. Laparoscopic is an alternate method to doing open surgery. It's minimally invasive. There's usually only a couple incisions. These are most common for liver biopsies. So I've explained all the ways to all the different biopsy techniques. So how do we acquire it? Kind of some tips and tricks on getting your biopsy. So avoid local contamination by using proper hemostasis and avoidance of getting seroma or hematoma formation in order to not seed cancer cells in different planes elsewhere. Placing drains in very extensive excisions and surgeries is very controversial due to placing a drain can spread cancer cells, but seroma formation can also spread cancer cells. So there's still research being done on are drains better or should we leave them out? Avoid the junction of normal and abnormal tissue, as when you close that biopsy site, if this does come back as a malignant tumor, you just seeded cancer cells all along your incision line, and if you go back in to take that mass out, you have much wider margins because you have to take out that incision as well now. And also avoid samples that contain only inflamed or ulcerated tissues. So for example, this guy right here, could say the owners want to know what this is before doing any kind of intervention, include amputation of the leg with how extensive it is. You won't want to take a sample from this kind of dead necrotic ulcerated area. You'd want to take a sample from this quote unquote healthier abnormal tissue. What other tips and tricks we can do? The larger the biopsy, the better. The more slides the pathologist is able to make, and the better diagnosis you can potentially get. Use a blade to take the biopsy, as laser and electrocautery can deform the cells of the sample and potentially make it undiagnostic. If you are doing a excisional biopsy, what if you want to know margins? Did you get it all? Is there any cells left behind? You can use tissue ink or suture tags and place descriptions in the history. So you can denote different sites, proximal, lateral, or deep margins based on which color ink, or I placed a suture tag at the proximal aspect of this. This is kind of what the pathologist would see under the microscope. So say the green margin was the lateral green ink was the lateral margin, the black was the medial margin, the proximal margin was blue, and the distal margin was yellow. He would be able to say, hey, we got all the cells, or hey, we didn't get all of them at the deep margin. You may need to go back or watch this area for regrowth of the tumor. So we have our biopsy now. we've done what we could to prevent any spread. How do we submit it and fix it properly? So we need to fix our biopsy in 10% buffered formalin, 1 part tissue to 10 parts fixative. For very large masses, you can do put them in a large bucket with formalin, let 1 part mass to 1 part formalin, and let them sit for 2 to 3 days before submitting them, making sure that the fixative infiltrates all parts of the tumor. Each biopsy should have their own container, and it should not be more than 1 centimeter thick. If we do have some of those larger tumors, you can bread loaf it in order to get it to that 1 centimeter margin so that tissue can be fixed by the formalin appropriately. Never freeze them, as when they rethaw, it can deform the architecture and if you not have a diagnostic sample when they go to stain it and look at it under the microscope. A detailed history should accompany all biopsy requests. That history should include the sigmoid of the patient, history, when they first noticed the mass, any reoccurrences if applicable, the rate of growth, where it was located, etc. And always request a microscopic analysis of your biopsies. If this is something that needs to go to oncology or an oncologist that needs further treatment, that microscopic analysis can help further treatment after getting that biopsy or surgery. So here's kind of I made a couple tables going through the advantages and disadvantages of cytology versus biopsy. So cytology, it's non-invasive, there's minimal pain, it's very cost effective. As with that picture, there aren't very many materials that you need, and they're generally cheap materials. Minimal instruments, you don't usually need any sedative or anesthesia. It's a very small needle prick that, as long as the patient is able to hold still, you should do it without any sedation. You can do many of them at once because they're done very quickly, and you can potentially have a fast diagnosis. You put it on a slide, you can potentially have a diagnosis when you put it under the microscope. Biopsy, it can provide a diagnosis and potential cure if it's excisional biopsies, and it gives a more complete picture of the disease process. As you can see, the tissue architecture that's going on, you can assign a grade to it and a prognosis for the patient. Disadvantages, cytologies, you can have false negatives. Sometimes they can be diagnostic, especially if they're very bloody tumors or tumors that are very necrotic and are very deformed and irregular. The cytology may not represent the fullness of the lesion. You can take as many samples as you want, but it still may not represent the entirety of the lesion. The sample quality may be poor due to the reason we have false negatives, and we can't evaluate the architecture of the cells in that sample. A biopsy, it's very invasive. Usually it requires a minimum heavy sedation, and sometimes general anesthesia if you're doing surgery or a very large excision. It is more expensive because you're paying for histopath and general anesthesia and potential surgery. You may need additional stains in order to grade it and diagnose it appropriately. It takes quite a bit of time to receive the results. It takes a while for that tissue to fix, for them to stain properly and prepare the slides appropriately. And it requires a pathologist to interpret them. So moving on from sampling to blood work. What we might see on our CBC, we can see an anemia. That's one of the most common abnormalities that we see, usually due to an anemia of chronic inflammation. But there are many etiologies of why we can get anemia. We can get blood loss. This can be acute or severe from acute/severe from a ruptured bleeding tumor, such as a liver tumor or a spleen tumor. Or we can have just chronic low loss over a long period of time, very common with our GI or our urinary tumors. It can get increased destruction of our red blood cells, causing an anemia. Hemolysis is very common in lymphomas, leukemias. It also occurs with hemangiosarcomas as due to a shearing process. As the red blood cells move through that tumor, they essentially get cut up because of the architecture of the tumor, causes hemolysis and an anemia. We can also have a decreased production of red blood cells at the level of the bone marrow, causing an anemia. If a cancer is affecting the bone marrow, we don't have the cells appropriate to keep up with the body's demand for red blood cells, so we don't have as many. We can also get an erythrocytosis, so too many red blood cells. This is most common in renal cancers due to an increase in erythropoietin, which stimulates red blood cell production. We can see a leukocytosis, so an increase in white blood cells. This is usually from the inflammation or necrosis occurring throughout the body due to the cancer. We can see a thrombocytopenia. There's a couple studies that were done that showed 36% of dogs that presented before treatment were thrombocytopenic, and 36% of cats already diagnosed with cancer were thrombocytopenic. This can be due for very similar reasons of why we had decreased red blood cells. So we have decreased production, increased destruction, we can lose them, or they can sequester places. The most common place they sequester is if we have an enlarged spleen. Spleen likes to hold on to platelets, and the most common reason for destruction would be shearing, similar to the red blood cell shearing in hemangiosarcoma. Another thing we can see is thrombocytosis. Cancer is one of the diseases that actually causes a significant increase in platelets. So if you see an increase of platelets on your CBC, I would be very concerned for cancer. Moving on to our chemistry, what can we see? This is not an exclusive list. These are just a couple that I was going to talk about. We can see hyperkalemia, most common in our insulinomas. They're releasing too much insulin, causing our blood sugar to go low. Hypercalcemia, cancer diagnosed in 60% of dogs and 30% of cats had an increased amount of calcium. In dogs, the most common cancers seen with an increased calcium are lymphoma and Agasakas. In cats with cancer, the most common cancers that they get with an increased calcium is lymphoma, multiple myeloma, and squamous cell carcinomas. Hypoproteinemia, mainly in our GI tumors, causing a loss of protein either in, usually in the gastrointestinal tract, but also not being able to absorb those proteins appropriately, so they don't get in the blood. We don't get them in our system. But also liver tumors, if they affect enough of the tumor, if they affect enough of the liver produces a lot of our proteins. It can be affecting the liver enough so that they aren't producing the proteins appropriately. And going along with that, if we have specifically mainly a liver tumor, we can have elevated liver enzymes. Going on to our imaging, what we can use for diagnosis, radiographs. Radiographs are used as a screening test. They do not provide a diagnosis. They provide evidence that a mass is present, and then you can go on to further imaging from there, such as abdominal ultrasound, CT, or MRI. This first picture compares a diseased humerus with a healthy one. So on the left here, this is a very healthy bone, nice cortex, nice medullary cavity. On the right here is osteosarcoma, where you have a very irregular lysis of the area. This bone actually lysed enough so that there wasn't enough normal bone, and it created a pathologic fracture due to the cancer. Abdominal radiograph showing a very large tumor, suspicious of either a splenic or a liver tumor. And then thoracic radiographs looking at, there's specifically a pulmonary mass here. Abdominal ultrasound. Abdominal ultrasound is the first line diagnostic for diagnosis and staging. It allows us to evaluate the internal structure of organs and better evaluate body cavities, especially if there's effusion present. It helps with localizing lesions, and a normal appearance on ultrasound doesn't exclude cancer. There can be infiltrative cancers such as lymphoma or mast cell that you still might want to take a sample of and rule out those as well. Ultrasound also allows for guided fine needle aspirate or biopsy. On the picture here, this is a picture of the spleen and with a large splenic tumor that is also cavitated with fluid inside. CT scans, it's more sensitive for detecting lesions, especially metastasis that is too small to be seen on x-rays. It gives more info on the presence, location, and extent of the disease, and it's the best modality for evaluating the nasal cavity, the head, and neck tumors, just because none of the other modalities, ultrasound or radiographs, can provide that much detail due to all of the superimposition of soft tissue structures and bony structures present. CT also allows for 3D reconstruction for surgical planning. On the left here is a thyroid tumor with quite extensive vascularization that the surgeon would want to know that before going in to cut this out. On the right here is a CT of the chest. These are the lungs and a irregular mass present, and this isn't done too often, but you can use CT to use a biopsy needle and make sure that you're getting the mass. MRI is the last one we can do, especially if you're seeing neurologic signs on the patient and are concerned for a brain tumor. This one shows a brain is here, head goes this way, neck this way, and there's a tumor in the frontal lobe here. So done with diagnostics, going on to why do we stage? We stage because, as I mentioned at the beginning of this, malignant tumors and cancer have the potential to metastasize. And metastasis is defined as the dissemination of neoplastic cells from a primary site to a secondary site where they proliferate from their own mass. Staging is the process of determining how advanced the cancer it is and if it has spread. This also helps determine treatment options and prognosis. Higher stage, poor prognosis. How can the cancer spread? It can spread through the blood system. These are usually your mesenchymal tumors. So your hemangiosarcomas, fibrosarcomas, osteosarcomas. The most likely place they like to go to is the lungs. Your round cell tumors, they like to go to your regional lymph nodes because they like to travel through the lymphatic system. These are your mast cell tumors, plasma cell tumors, histiocytic sarcomas, and transitional venereal cells sarcomas, tumors. Lymphoma is considered already a systemic disease, so it does not metastasize. It is already considered systemic wide. And then epithelial tumors like to do both. They like to go to regional lymph nodes or the lungs or other organs. These are your agasacas, your apocrine gland, anal sac adenocarcinomas, your squamous cell carcinomas, your mammary carcinomas. What steps must occur for spread to occur? Cancer cell must leave its primary tumor and enter the circulation, one of those three that I went over. It must resist apoptosis and evade the immune system. Once it's at the distant site, it must leave that circulation, survive the environment in foreign tissue, and receive signals to proliferate and create a new mass. This is just a diagram kind of going through that. So primary tumor must leave through various different ways, evade the immune system, exit the circulation at a distant site, form a new mass, and create a measurable mass that can be seen on imaging. How do we stage? Staging can be done at the same time you're doing diagnosis, as many of the diagnostics are the same. We can do radiographs, we can do abdominal ultrasound, CT scans, and MRI. Specifically, we can do a fused CT or MRI with PET scan, which is positive emission tomography that I'll go through in a bit. Don't forget, we also stage using our core diagnostics of a CBC, a chemistry, and urinalysis. Radiographs. This shows the primary tumor here, which is an osteosarcoma. As I mentioned earlier, osteosarcoma is likely to go to the lungs. All of these little masses present in the lungs here are metastasis of this primary lesion. Abdominal ultrasound. This shows a picture of enlarged lymph nodes. That could be a round cell tumor or a epithelial cell tumor that likes to go to those lymph nodes. CT scan. This arrow shows a very small lesion that was not initially picked up. Chest x-rays. So it is much more sensitive for detecting metastatic lesions. And then we can also use MRI. This is a picture of a brain and a metastasis of suspected hemangiosarcoma to the brain. PET scan is a modality that combines imaging with nuclear medicine using radioisotopes. It highlights highly metabolic cells that have increased glucose metabolism. So this includes both tumors and inflammation. In this picture, the arrow here shows the primary tumor at the radius and ulna. These little asterisks are lymph nodes that have increased metabolism, and the big arrows here are the vertebrae and the scapula that indicate metabolism of this primary lesion. We can combine PET scanning with a CT in this case, or we can combine it with MRI. And my references. And any questions from you guys?
All right, so we don't have any questions as of now. Just to let everybody know, you will get your CE certificate. It should be emailed to you by the end of this week. If you don't have that, you can always give us a call or email admin@IndyVet for the CE certificate. And then if they want to ask any questions, Dr. Liles, do you have an email that they can send you?
Yes, you can send it to my IndyVet email, which is mliles@indyvet.com.
All right. Thanks. You guys all.
Thank you guys.